You've already listened to the section on hypofluorescence, and now we're going to change and talk about hyperfluorescence. There are three main reasons for hyperfluorescence, and that will be transmission, leakage, or abnormal blood vessels. The transmission is where you are seeing normal fluorescence that is normally blocked, and then the other portion of hyperfluorescence is leakage coming from abnormal blood vessels that are normally present in the retina, but they're abnormal, or abnormal new blood vessels. And we've broken this down into two different sections. If you see more fluorescein than you should, it is called hyperfluorescence. There are two reasons why this may occur. The first reason is that something is missing, such as the pigment epithelium. This finding is described as either a transmission defect or a window defect because you can see the normal choroidal fluorescence, which is usually blocked by the retinal pigment epithelium. The two other situations which may lead to hyperfluorescence are leakage from diseased tissue or from abnormal blood vessels. There are many entities which can affect the density of the pigment in the retinal pigment epithelium. The RPE can atrophy, as is the case in geographic atrophy of macular degeneration. If drusen form under the RPE, often the pigment will decrease in that portion overlying the drusen. Injuries, laser, trauma, and some drugs can disrupt the pigment as well. Choroidal folds will cause hyperfluorescence at their crests and hypofluorescence at their base. And then finally, there's a special condition we can find in macular degeneration, and that is called an RPE rip. We'll start with some examples of macular degeneration. Before we begin on the different disease entities, let us review a chart comparing the fluorescent patterns of transmission defects and leakage. The transmission defects, or a window defect, begin early as there's no pigment epithelium to block the choroidal flush. So the early phase has 1+ mark. The fluorescence will increase during the mid-phase as more dye flows into the choroid, and then fade in the late phase as the dye is washed out of the choroidal circulation. So in transmission, the mid-phase has 3 pluses because you can see the dye much better, and the late phase, there's only 1 plus because the dye has been washed out of the choroid. Also, the hyperfluorescence will have sharp borders, and these will match the borders of the lost RPE. With leakage, there's no abnormal hyperfluorescence initially because there are no abnormal levels of fluorescein in the abnormal vessels. As the serum leaks out of its normal area, i.e. in the normal retinal vessels, the fluorescence will accumulate, and you'll see the hyperfluorescence gradually get more and more. And this is the case whether the serum, and therefore the fluorescein, pools in a space or stains tissue. Here's a patient with bilateral geographic macular degeneration. The arrows point to the sharp demarcation line between normal RPE and absent RPE. Inside the geographic area, not only is the RPE totally atrophic, but also the outer segments of the retina and also the choriocapillaris. You can see the large choroidal vessels. Some are red, carrying blood, and some are sclerotic. Here are 2 phases of the angiogram of that patient. The left photograph is the earliest. You can see the larger choroidal vessels as well as the medium vessels, which are normally blocked by the retinal pigment epithelium. The right photograph is the mid-phase. Because there is more dye in the choroid, the area of the geographic atrophy becomes more fluorescent. But you can see the borders do not change and they're very sharp. Here's another comparison of the early and late phases of a window defect. Note that while the fluorescence is more intense in the late phase, the area of the hyperfluorescence does not change. And note they continue to have sharp borders. The choroidal vessels do not have tight junctions, so the fluorescein naturally leaks out of them and stains the interstitial tissue of the choroid as well as the sclera. Here is another example of geographic atrophy. Note how the hyperfluorescence exactly matches the area of the loss of the RPE. The borders of the hyperfluorescence match the borders of the loss of the pigment epithelium, even down to the tiny area of intact RPE in the center, which blocks dye as it should. The blue arrow on the color photograph points to the small area, and as it does on the fluorescein angiogram. You will see many clinical variations of geographic atrophy, but the general transmission defect rule will hold for all cases. Here's a patient with many medium-sized drusen. Drusen are under the pigment epithelium and are on Bruch's membrane. They can be yellow or white, and sometimes the pigment epithelium is thinned out over the surface of the drusen. There's a variable pattern of fluorescence on the angiogram because some drusen seem to be hydrophobic and therefore block the dye, and some hydrophilic and it will attract and therefore absorb the fluorescein dye. Note on the angiogram, the hyperfluorescence of the drusen does not change in size, however, throughout the angiogram. The larger drusen near the fovea partially block dye early and they stain late. This is a 73-year-old female who has a choroidal neovascular membrane in her fellow eye. The left eye has some obvious drusen near the fovea. Note on the angiogram here that you can see not only the drusen you could see clinically around the fovea, but there are others in the nasal macula that you cannot see on the clinical slide. Also, in the far superior area of the photograph, there's leakage from a peripheral choroidal neovascular membrane. As you can see on the slide here, many other entities can cause window defects where there's damage to the pigment epithelium. This may be thermal, as in light or laser toxicity. Now you'll see these as window defects on PRP or other focal photocoagulation cases, angioid streaks, medical toxicity, chronic neurosensory detachments such as in chronic central serous choroidopathy, choroidal folds, and also retinal pigment epithelial rips. This is a 22-year-old type 1 diabetic who has had pan-retinal laser photocoagulation. You can see the laser scars in the mid-periphery. Some are pigmented and some are hypopigmented. The hypopigmented laser spots are pointed out by the yellow arrow and will act as window defects on the angiogram. The white arrows point to some residual fibrosis because this patient has had a vitrectomy. The red arrow points to some residual retinal hemorrhaging. Here is the early, mid, and late angiogram of the patient. Note that the laser scars can be seen early, as this hyperfluorescence is secondary to a window defect. They can be seen more in the mid phase, and then they will fade a bit in the late phase of the angiogram. There's also diffuse hyperfluorescence near the fovea, secondary to leakage from the retinal capillaries. The white arrow points to areas of hypofluorescence, and this is secondary to capillary dropout. This patient had a very routine surgery for a macular hole. There's nothing unusual during the surgery. However, he suffered photic burns. This happened before we changed the wavelength on our light pipes for vitreous surgery. You can see the hyperfluorescence from loss of the retinal pigment epithelium and hypofluorescence from pigment proliferation as a response to the light injury. As I mentioned, our fiber optic lights have now changed the wavelength so that this particular complication does not occur. Angioid streaks are breaks in Bruch's membrane with overlying retinal pigment epithelial atrophy, and they will have a very specific pattern of hyperfluorescence, and we will show this now. This patient has angioid streaks. She has 3 reasons for her hyperfluorescence. Centrally, there's an area of atrophy and loss of the pigment epithelium, and this is similar to the geographic atrophy that you see in macular degeneration. The angioid streaks are breaks in Bruch's membrane, and there's overlying loss of the pigment epithelium. The blue arrow, both on the color photograph and on the angiogram, points to one of the many angioid streaks. This patient also has a neovascular membrane and a small hemorrhage, and the white arrow points to the leakage from the net. There are many drugs which can affect the pigmented epithelium. The one we see most frequently is Plaquenil, but phenothiazines such as thorazine and Mellaril can also cause damage to the RPE. Hopefully, you will never see this late-stage toxicity from Plaquenil. This is a 44-year-old female who has taken Plaquenil for about 20 years and has complained only recently about a visual blur. You can see the bullseye hypopigmented rings around each fovea. And here's this patient's fluorescein angiogram, and you can see the very well-developed, sharply demarcated areas of window defects secondary to the loss of pigment epithelium. Chronic neurosensory detachments, such as chronic central serous choroidopathy and choroidal folds, are specific entities, and these will be covered in other chapters. Our final example of transmission defects, which you will see, is a subgroup of macular degeneration. It is a complication of a retinal pigment epithelium, and it is called a retinal pigment epithelial rip. These are most often caused by fibrovascular membrane under the RPE. As it contracts, it will rip the RPE blister. Here is a 70-year-old male who has an RPE rip. He had a sudden loss in the left eye about 1 month prior to presentation. His vision is 2200. The yellow arrows point to the border where the RPE detachment was before it ripped. The yellow area inside of the arrows is bare choroid. The brown arrow points to the curled up RPE. The early hyperfluorescence comes from the choroid, and later on there is staining of the choroid. But note, the extent of the hyperfluorescence does not extend beyond the area of the loss of the retinal pigment epithelium. Both the curled up RPE, which is now thicker than usual, will block dye, and the retinal hemorrhage also is blocking dye on this angiogram.